Okay, so good morning, everyone. So today we'll continue with the content on the nervous system and the physiological or physiological alterations and diseases that affect the nervous system. And this is continuation from previous classes, or from Tuesday and Thursday class, and the last content for on the nervous system will be completed today. So towards the end, as I said, I will briefly go over the neuropharmacology and the mechanism of action for like how the drugs work on the nervous system, especially the sympathetic and parasympathetic nervous system. So any questions before I begin or start the last content for the nervous system? Anything you want me to repeat it, or a concept or mechanism that you found is very difficult to understand? Anything that you want me to review? All right, so the two presentations will be done towards the end. Now that we said that the CPA, I did cover that during the week on Tuesday and Thursday lecture, but it's just I will reiterate and repeat what I have said to make sure that you understand the CVA or stroke very well, because that's one of the most important topics. And patho, and also we will revisit stroke and adult health mid-surg courses. So the stroke, we said it's classified as either a thrombotic blood clot has already formed in the blood vessels in the brain, or it is hemorrhagic or embolic. So thrombotic, that's when the blood clot forms in the brain. Hemorrhagic, when there is a bleeding or hemorrhage in the brain, cerebral, like intracerebral hemorrhage. And embolic, when the blood clot dislodged from somewhere else and travel to the brain and cause the CVA or stroke. We call the stroke or CVA, which is cerebral vascular accident. And also we call it, some textbooks refer to it as a brain attack, like heart attack. So brain attack, stroke, CVA, or brain attack. So I have some prevalence and some data about the stroke. And which occurs when there is an ischemia to a part of the brain that results in death of brain cells. So the hallmark disease, concept is the ischemic changes in the brain cells due to the depletion or decreased perfusion. And that could result, and that decreased perfusion will result in ischemia, and then the death of the cells in the brain cells. And I have some data about the stroke on the slide. So as for wording, yeah. So this is what I'm trying to refer to in terms of the prevalence and the numbers. As you know, as a stroke or CVA is the third most cause of death in the U.S. and Canada, leading cause of serious and long-term disability. Approximately about fourth, which is 25% of individuals who have the initial stroke die within 1 year. Another statistics or uh, epidemiological concept is that it's the leading cause of disability, and it's the third leading cause of death in the United States. So the pathophysiology um, that explains the stroke, it can be classified into either hypoperfusion and like as if the patient is experiencing shock, decreased perfusion, blood supply to the cells in the brain, or it's the ischemic changes of the presence of the blood clot has occluded the blood vessel, or the embolic, which is the blood clot which has dislodged from like a DVT or from the pulmonary embolism or from the heart and travels to the brain and cause the ischemia and cause the CVE and then the ischemic changes and the decreased perfusion. So, and the third type we said it's hemorrhage, bleeding within the brain cells. So that's just the three possible causes of the stroke. And this slide explains the risk factors as modifiable and non-modifiable. And we'll get to the pretty much, I would say, similar classification when it comes to cardiovascular risk factors. We have some modifiable risk factors that we can modify, right? And non-modifiable, we have no control on: gender, age, race, heredity or genetics or familial, predisposition. So the modifiable, all these we have a lot of room to work on changing and modifying and altering these modifiable risk factors, especially when it comes to lifestyle habits and managing, and altering or changing the lifestyle habits. The or weight or the chronic diseases and control the chronic, like the patients diabetic, and it's one of the modifiable risk factors. So controlling the hyperglycemia is one of the preventive measures to prevent the CVA, for example. Being hypertensive, controlling the hypertension will help, or at least prevent the CVA to some extent. And we have some percentages or the benefit of controlling the the high blood pressure, hypertension. You can lower or reduce, and this is based on research studies and based on the evidence-based practice, that you can reduce the CVA or stroke incidence or the incidence by 50%. The CVA can be reduced by 50%. The etiology and pathophysiology, again, the CVA, the pathophysiology of the CVA connected to that concept, which is the perfusion and the ischemia. Blood supply to the brain takes two channels or two major arteries: internal carotid artery and the vertebral arteries. Two major arteries that will supply the brain cells with perfusion or blood. Now, I mentioned yesterday or Tuesday that the blood flow to the brain is when it's totally interrupted, a complete cut of blood supply, complete occlusion, obstruction and the blood vessel, thrombosis, thrombotic or bleeding resulted in ischemia or inflammatory response and edema and ischemia, or embolic, the same thing, which is the blood clot has dislodged, been dislodged and then traveled to the brain. So the blood supply will be interrupted in the brain to the affected site in the brain, and the within 30 seconds, the metabolism will affect the neurons, which is called the neurologic metabolism, will be altered and affected, which takes only 30 seconds to happen or to take place. The metabolism will completely stop if the blood supply is interrupted longer than 2 minutes. This is only affect just the affected site or place in the brain in which that the brain cells is perfused by that specific blood vessel which has been obstructed and resulted in the interrupted blood supply. But after 5 minutes, cell death or brain cell death will result. So that's why we always say 5 minutes is the maximum time in which you can prevent brain cell death. You have to maintain perfusion. You have to resume perfusion to the affected brain cells, otherwise the brain cells will die. So there is some, in some scenarios you will have complete blood supply, but brain, cells doesn't, completely result in death of the cells because of the collateral circulation. Collateral circulation, which is the blood supply of small tiny blood vessels that grow on both sides of the blood vessel, of the main one. So around the main blood vessel, you will find like small tiny blood vessels that will grow, and these are usually present in the brain vasculature and in the heart as well, like patients with a CAD, coronary artery disease, and they have a complete blockage of one of the coronary arteries, but they still, that doesn't result in the death of the cells in the myocardium because there is a good collateral circulation. So collateral circulation is the tiny blood vessels, small blood vessels that grow on both sides of the large blood vessel, and these are affected by two factors. Patients who have chronic ischemia, and also it has a genetic factor. Some people have, tendency or familial or genetic, predisposition to have more collateral blood vessels in circulation than others, because this can save the cells and prevent their death, because that's going to supply them with some perfusion. It's not going to be excellent and same as the main blood vessel, but some perfusion. So read about collateral circulation. It's a very important concept in cardiac and in the nervous system when it comes to cell death and perfusion and the ischemia. So the factor that affect the blood flow to the brain, the blood pressure. So you need a good blood pressure, which we are going to cover in cardiovascular system in terms of how would you assess and measure the blood pressure being effective, systolic over diastolic. We need two good numbers that will provide us indication that the brain cells and the brain is going to be perfused from this blood pressure. In other words, is 100 over 60 a good blood pressure, or maybe 130 over 80? Which one is better? So there is something called MAP, mean arterial pressure. The mean arterial pressure, which is systolic, and I'm going to cover this in cardiovascular, so I don't want to go over lots of cardiovascular here, but this MAP is called mean arterial pressure, and you calculate that as you add the systolic plus diastolic. So let me just stop sharing this and show you how we can measure the MAP, because it's a very important concept in cardiovascular and then as well as in the nervous system or the neuro. It's called MAP, mean arterial pressure. It's systolic blood pressure plus 2 diastolic blood pressure over 3. So if you say that, sorry, if you say 100 over 50, is it good blood pressure or not? It's hard to determine from the systolic and diastolic if that's a good blood pressure, because we are concerned about the perfusion to the vital organs, brain, kidneys, liver, right? These are the vital organs, need good perfusion, vital organs. So the first one to consider today about nervous system is the brain. Is the brain getting enough blood from this blood pressure? So you will do the map is the systolic and diastolic is not sufficient. The best indicator of the perfusion is map. Do this. You will say 100 plus 2 diastolic, which is another 100, and that will be over 3, and that will be 200 over 3, and it will be about like 60, maybe 8 or 69. It's slightly less than 70. So which means that this is fairly close to the number we need, or to the optimal number. The optimal, which is not the optimal, but the minimum. Stop share. Let me just go back to the slide. The minimum map needed is 70. Make sure that you know the map for your patient. So regardless of the blood pressure, it can be like 130 over maybe like 90. That could be a good one, because you determine the map, you determine if that blood pressure is going to provide good perfusion to the brain from the map, MAP. So if you do systolic plus 2 diastolic and you divide the number over 3, then you get any number over 70 is great. So we need a minimum of 70 map to assure or to make sure that the brain is getting enough perfusion. And that's how you evaluate if the brain is getting enough perfusion. So the factors that affect blood flow to the brain, the first one is blood pressure. Don't rely on just systolic saying that it's 100 or 110. As long as it's over 100, then it's a good blood pressure. It's not enough. It's insufficient, and it's not the best indicator of the perfusion, the systolic. Because most of the people say, as long as my systolic is over 100, then I'm good, I'm okay, my brain's getting enough, and my vital organ is getting enough perfusion or blood. No, you have to go with the map. That's the best indicator of perfusion. The second factor that may affect the blood flow to the brain is the cardiac output. Is the cardiac pumping enough blood to the brain or not? Patients with cardiac problems, they may end up with syncope. Syncope, which is fainting, because they don't get enough perfusion to the brain cells because of that cardiac problem. And then the blood viscosity, which is the viscosity of the plasma, and in which that hyper or increased viscosity will result in blood clotting, tendency to develop blood clots and thromboses and thrombotic CVA. So these are the three main factors that govern the blood flow to the brain. We said blood pressure, MAP, because some, even the textbook, they say systolic, but it's supposed to be the MAP, mean arterial pressure. Second, cardiac output, and the third is blood viscosity. The increased viscosity, it will result in a tendency to develop the blood clots in the brain. So the atherosclerosis, which is the hardening and thickening of the arteries, and that's one of the major causes of stroke. So the CVA.
Professor,
Yes.
what causes the blood to get more viscosity?
This one actually we are going to cover in hematology. So I don't want to go into there's something called Verco triad, and the Verco triad explains the three triads, or the three arms of the theory that explains the thromboses and why people will get thromboses or tendency to have blood clots more than others. And so that's the kind of a long, I would say, like discussion when it comes to the we call it coagulability, coagulation, and viscosity of the blood and blood clotting. It's a kind of long discussion. So let's just delay this to the when we get to the hematology system. Um, the so it's just for now that just say that viscosity or blood increased viscosity will result in blood thrombosis. So in response to the ischemia, all these the following will follow or result, which is called the ischemic cascade. It's like sequelae of events that will follow from the ischemia, and which is the last step or stage would be the death of the brain cells. It says here that if adequate blood flow can be restored early, which is within 3 hours, the ischemic cascade can be interrupted. Now, you will revisit this concept in adult health too when we get to the stroke and CVA, and one of the treatment modalities or the medications called tissue plasminogen activator, which is the thrombolytic drug, and that is good for patients who are with a thrombotic or embolic stroke, not hemorrhagic. So we need to dissolve the blood clot, which is thrombolytic agent or medication. It's good if it's administered within 3 hours, or we go up to like 3.5 hours. After that, it's ineffective. So that's the explanation. If you take this, keep it, write it down. When we get to the stroke and adult health too, that is the reason why that TPA drug won't work after 3.5 hours. Because if we restore the perfusion to the brain cells within 3 hours, or within less than 3 hours, we said here. So which means within 3 hours, the ischemic cascade, which could have resulted to the cell death of the cells in the brain, that can be interrupted. So I'm just going to briefly, because I did explain how the AFib results in or cause the CVA. And we said that how many times you see you encounter or have patients or take care of patients on Coumadin, and they have no like I would say indication or a disease that require that they should be on Coumadin, other than they have an AFib, atrial fibrillation. So they, if the patient asks you, how come I don't have any disease that is connected to because when you give the Coumadin anticoagulant medication, anticoagulant drug, that has to be given to or administered to patients who have already developed thrombosis or blood clot. They have problem with the clotting, and you have to extend the clotting time. That's why they will be on anticoagulant, which is, we call it blood thinners, which is warfarin, sodium, or Coumadin. Here with AFib, and this is for patients with AFib, chronic AFib, and never, let's say that they have never experienced any CVA in the past. So no history of CVA or stroke. All of what they have right now is an atrial fibrillation as diagnosis. So the connection between the AFib and the stroke is that when you give the Coumadin, the anticoagulant, the blood thinner, is just to prevent the blood clotting. So how AFib would result in blood clot and thrombosis, it's because the atrial fibrillation means the atria are quivering, they are not contracting normally. So there is, with that quivering activity, it results in the stagnation of blood and pooling of blood in the atria. So lots of blood will be retained after the atria will attempt to empty the blood into ventricles after the atrial systole, so that so more blood will retain in the atria. And then the more blood retains, that will result in tendency for blood to clot. So to prevent that blood clotting, we have to make it less viscous and more thin. So which means blood thinner. So anticoagulant prevent coagulation, prevent blood clotting. So we give them the Coumadin for that reason. So the AFib, atrial fibrillation, quivering of the atria, result in incompetent contraction of the atria, more blood pool and stagnant in the atria. And anytime you hear that blood pooling or stagnation of blood, automatically you think of predisposition to blood clot. Same thing with varicose veins. When we get to the vascular system, we talk about varicose veins. They also at high risk to develop the blood clot from that pooling of the blood and stagnation of blood in the lower extremities due to the incompetent valves and the veins in the lower extremities. So that's the concept behind the atrial fibrillation and the tendency to develop the CVA or stroke. We said that we classified stroke as the either thrombotic or embolic or hemorrhagic, and under the thrombotic and embolic, both of them you can classify them under one major or one main umbrella as ischemic stroke. Ischemic stroke. We have another mini, like we sometimes you call it like you can call it a mini like stroke or on the scale of the stroke as tiny or small stroke, because it's called a transient ischemic attack, which is a TIA. Now the TIA, it's the lower scale of a CVA, because that is a tiny blood clot that has formed and resulted in some minor symptoms. Sometimes patients report that they have like minimal weakness or numbness or of the one of the side of right side or left side of the body. They have like sometimes even just numbness of the facial right or left side of the face. So these kind of minimal manifestations, it's usually it will resolve, which will be resolved and disappear within 24 hours. And that is called TIA or transient ischemic attack. The problem with the TIA is the frequency. If the patient develop more than one TIA, then they have to be evaluated, or at least they will be at high risk to develop a CVA in the future or stroke in the future, because they already have one or more of the TIAs, which is like the lower scale of CVA or stroke. We talk about the embolic stroke, like the patients with an AFib is an example of that. Another example of the embolic stroke would be like patients with DVT or pulmonary embolism, and when the blood clot dislodge and travels to the brain and then it stays there, that is also called embolic stroke. Hemorrhagic, which is the intracerebral cranial hemorrhage within the cranium and the brain or around the brain, and that is the hemorrhagic stroke. The treatment modality is the treatment for ischemic. So we said ischemic, you can put under ischemic the thrombotic and embolic, and then another classification called hemorrhagic. So ischemic and hemorrhagic. That treatment is going to be completely different when it's ischemic from patients who had developed the hemorrhagic stroke. Because with ischemic stroke, you can use anticoagulant medication or thrombolytic drugs, but hemorrhagic stroke should not be used. There's something called lacunar stroke, which is a small, very small, tiny stroke that is less than, smaller than 1 centimeter diameter, involving the small perforating arteries. And people who would be affected by that, like hypertensive patients, diabetics, or patients with diabetes. Smoking would also result in lacunar stroke. The difference between this slide just shows the how thrombotics, how the blood clot has formed in the brain cells. embolic, that's the blood clot which has been dislodged from, let's say, like a DVT from lower extremity and travels up to the brain and stays there. And then here we have a rupture of the blood vessel, which resulted in a hemorrhagic stroke. This is the difference between some of the difference, I mean, in terms of the signs and symptoms of, or the resultant uh, complications and manifestations of the left side versus the right side. Now, I did mention during the week that that we have to specify: are we referring to the weakness, which is the resultant manifestation of the disease, or the actual impact on the brain? The actual impact on the brain, we can say that right side brain attack, which means that the right side of the brain has been involved or affected by the stroke. But if the question says right side weakness, then it is the weakness and the affected side of the body. But implicitly stated, automatically you would know that the left side of the brain has been affected. So if there's a hemorrhagic stroke with right side weakness, we will know that the right side of the body will be affected. Paresthesia, like weakness. I'm sorry, paresthesia, which is like numbness. Paresis, hemiparesis, right hemiparesis, which is the right side of the body, weakness of the right side of the body, or hemiplegia. Hemiplegia, which is complete paralysis of the right side, the right arm and the right leg, right? So right hemiparesis, which is the numbness of both right upper arm, upper limb and the lower extremity, upper extremity and lower extremity. When you see a hemiparesis, means the weakness of the right upper extremity and the lower extremity. And if you say right hemiplegia, which is the complete paralysis of the right upper extremity and lower extremity. So anytime you say right weakness or right hemiplegia or right hemiparesis, you implicitly, automatically would say that the left side of the brain has been affected. Same thing, patient with a left side hemiparesis, right, left side hemiparesthesia or paresis, which is weakness, or plegia, left side hemiplegia. The left side is affected or resultant manifestation, but the implicitly stated, we will know that the right side of the brain has been involved or affected by the stroke. I'm gonna just make sure that you read the question and read the statement well. Are we talking about the brain or about the resultant effect from the stroke, which is most of the time it is the weakness or numbness or the paralysis of the affected side of the side. I mean of the body, right side, left side. And these are some of the differences between when the right side of the brain is affected, like in terms of damage due to the brain attack or the stroke, and that you would expect in patients with the left brain damage, given the function for each one and physiological functions for each side or hemisphere of the brain. We'll have some questions, and I will go over some details about this slide. Aneurysm, intracranial aneurysm. This is just informational. It's just to know what is aneurysm is, and that one of the also common and dangerous, life-threatening scenarios that when the patient have something called AAA, which is abdominal aortic aneurysm, for example. And the problem with the aneurysm is that sometimes it will go unnoticed, or patient will be asymptomatic, and all of a sudden is that the aneurysm is going to rupture, and that will result in a severe bleeding, especially when it comes to the brain. Here it's intracranial, or when the aneurysm in the abdomen, which is the aortic, when we say aortic aneurysm, which means it's the largest artery in our body. Imagine that that aorta will rupture, and that will result in severe bleeding, and that most of the time is lethal. I mean, it can result in people's death, or patients, will die from the aortic aneurysm, AAA. So it's very difficult to even to treat and to save people's life, because given the massive bleeding and hemorrhage internally. So this is an intracranial aneurysm. So the aneurysms always result from the what is called the weak walls of blood vessel, and it can be on one side or both sides. So it can affect like this, the Barry aneurysm, which affects only one side of the blood vessel, and there are other aneurysms that would affect both sides, like this one, both sides of the blood vessel. But the bottom line here is that aneurysms, these walls are very weak walls. They are not strong enough like the rest of the blood vessel. So these are very weak, and the rupture of the there will be easy ruptures with any force or with any pressure, sometimes even internal pressure, internal like intrathoracic or intra-abdominal pressure or intracranial pressure will result in the rupture of these uh, aneurysms. The sorry. Now the risk factors that would contribute to the aneurysm. Sorry, I'm just trying to see if we have risk factors. So some of the risk factors that would result or contribute to the formation of brain aneurysm: smoking, number one; high blood pressure or hypertension. Some aneurysms are congenital. People are born with these aneurysms, and they will grow, will grow up and age to their maybe 60s until they discover they have an aneurysm. By just accident, they go for a CT or for MRI, and they will find that they have an intracranial aneurysm or aortic aneurysm or any type of aneurysm. So that sometimes goes unnoticed until the patient is either will diagnose it by accident, or patient develop a complication or signs and symptoms, like especially in this case would be like a hemorrhage. The other risk factors, we said genetic, family history, and age over 40. In addition to gender, that women compared with men have an increased incidence of aneurysm at ratio of like 3:2, men to women. The presence of something called AVM, the arteriovenous malformation, AVM, that also can be a risk factor, which looks like this one. See this one, like the spaghetti kind of blood vessels in the brain. This one is called uh, AVM, which is the
Was that again?
arteriovenous malformation. Yes, yeah, arteriovenous malformation, in which that the you will hear that for those patients, you hear something like when you auscultate, when you do the assessment on the carotid artery in the neck or mastoid process behind the ear or the eyeball, you can you can hear something called systolic bruit. Systolic bruit can be heard over the carotid artery in the neck, around the neck, which is in which where the carotid arteries are located, or the mastoid process, or the eyeball. You do the auscultation, and you can hear the bruit is called systolic ROI, and that is significant when it comes to the AVM. Subarachnoid hemorrhage, um, which is the bleeding um, into the subarachnoid space. Patients may exhibit these two signs. You'll find also these two manifestations, which is the Koenig sign and the Brzezinski sign. You can find them also in patients with meningitis as well. Patients with meningitis will exhibit these two signs, um, as well as the subarachnoid hemorrhage. So the case study on CVA, do we have to go over this case study to read it, or I mean the scenario, or you already have done that? If not, then we need a volunteer, please, to read it aloud. And volunteers to read aloud the
Okay.
scenario. Thank you, Amy. You are muted, Amy. Muted.
Muted?
Yeah, yeah. You're good.
I bet
Okay,
you
you're
can.
all right. You're good.
Bonnie is a 70-year-old woman who lives alone. One evening, she felt lightheaded and dizzy. When her head began to ache, she decided to take an analgesic and go to bed early. The following morning, upon awakening, she was unable to move the bed sheets with her right arm. At this point, she was experiencing tingling sensations in her limbs, and she had difficulty keeping her balance. She dialed 911 for help, and by the time the ambulance arrived, she was confused and unable to articulate her words, although she knew what information he was asking of her. In the hospital, she was examined and treated for ischemic stroke.
So let's together as a group, everyone try to underline and or highlight the words, statements, or sentences that are consistent with. It can be patho, it can be manifestations, can be anything that is connected or related to stroke or CVA, based on what we have discussed, um, uh, earlier. So anything that you think, so this is like brainstorming. Anything that you believe that it is connected to the stroke, highlight it, underline, because that will help understand how to use case studies and in discussing the the pathophysiological alterations of certain diseases. Okay, so you want to tell us what they have done in terms of underlying or highlighting? Anything that is stroke related or CVA related.
Confused and unable to articulate her words.
Okay, which is what would you call that in terms of the medical terminology? Because these are the patient's words. Now when we talk like medical um, terms, that is it has a specific medical term.
Is that aphasia?
Right. So so we have two different terms. We have dysarthria, difficulty of speaking, difficult speaking, and then the unable to speak, aphasia, unable to speak at all, aphasia, dysphasia, which is difficult speaking, dysarthria, it's like slurred speech, dysarthria. Any other concepts or manifestations or Anything that pertains to the stroke or CVA?
She was experiencing tingling sensations in her neck.
Perfect, yes. Which is significant for neuro manifestations or manifestations pertains to the nervous system because of it's a sign of one of the signs of CVA or stroke. What about the unable to move the bed sheets with her right arm? That could be the weakness or complete paralysis. So right hemiplegia or right hemiparesis. The tingling sensation of the right um, of her limbs that was supposed to be the right side, both right arm and right leg, then that is a tingling, which is the right hemiparesis. I'm sorry, right prosthesia, right?
Yeah, prosthesia.
Yeah, paresthesia, which is the tingling sensation. What else do you have here?
The lightheadedness and dizziness.
Yes, good. Yeah. So let's go to the first question. Yeah, I'll try to be brief. I don't want to go into this is only it sounds like it's an advanced scenario, but I'll try to limit it to the scope of this class. So I won't go, beyond to to advanced path or things that you don't need at this point. Just make it very simple and very basic. The first question, anyone want to read the first question, please?
Did you say anyone or me?
Yeah, anyone. No. And we need other volunteers other than Amy. Other volunteers.
I can read it.
Okay, go ahead. Thank you.
It says a stroke or brain attack involves brain tissue injury. Describe ischemic numbra
Numbra.
and what factors contribute to the survival of the neurons involved. What happens if the cells of numbra are unavailable to preserve?
I know this is one of the difficult questions. Sometimes I skip this one for patho. It's just very briefly. The ischemic numbra, which is on the X-ray or the CT, you'll find a blood clot, and around it a halo kind of spot or grayish kind of area. That ischemic, so it's a band of neurons surrounding the core of dead or dying cells, and that's because of the vascular accident. Now, that's just briefly. If these noxious conditions persist, the cells of that numbra will die, which means that it has to do with the recovering the brain cells to prevent the death of the cells. It's kind of one of the, I would say, advanced patho is just when you hear numbra, just know that it's the area around, which is the band of neurons surrounding the core of the dead dying cells in the CVA. It will be revealed on the diagnostic studies as a halo or grayish kind of area around that blood clot. So I'm not going to spend time on number one because I know that this is a little difficult question, and I won't even expect that you'll even know the answer. Number two. Volunteers.
Compare and contrast hypoxia and ischemic. What condition is more dangerous? Brain. Explain your answer.
So hypoxia and ischemia, any difference?
Yeah, hypoxia is low oxygen and ischemia is no blood flow, right?
Excellent. So it's very important to differentiate between these two concepts. They are conditions that involve alterations, both of them, alterations of oxygen availability at the tissue level. So hypoxia as Theo said, it's a term used to describe the lack of oxygen at a given site. Although the blood circulation to the area is intact. So this can be a good perfusion to the area. It's intact perfusion, but the tissue became hypoxic because we didn't have enough oxygen supplied. But with the ischemia, automatically you think of perfusion. On the other hand, it's described as the lack of blood circulation or perfusion to the area. So hypoxia, oxygen, depletion, ischemia, blood supply decline or decrease. Or so in ischemia, tissues are vulnerable not only to oxygen deficiency, but also to glucose deficiency. Because remember, in ischemia, everything is is not getting to the circulation completely cut off to that specific tissue. It's not just the oxygen. Everything, glucose is not going to be supplied because of perfusion. So in ischemia, tissues are vulnerable not only to oxygen deficiency, but also to glucose deficiency and the accumulation of metabolic wastes. So it's important concept in stroke because the brain is able to maintain limited cell activity by anaerobic metabolism. Because in the absence of the oxygen, they have to turn the anaerobic metabolism, and they can tolerate that. They can live, within a limited cell activity by this anaerobic metabolism in the absence of oxygen, and therefore they are able to survive for some time in a state of what is called a state of hypoxia. With ischemia, given that the complete cut of blood supply, nutrient stores are rapidly depleted and not replenished. So the lack of blood supply in ischemia means that the metabolic waste accumulates at the cell level, create a state of acidosis. So which one is more dangerous, ischemia or hypoxia?
Ischemia.
Ischemia. So the ischemia is therefore is more detrimental to the brain tissue than hypoxia, given that this distinction or the difference between ischemia, hypoxia, and ischemia. Number 3.
Knowing what you do about the effect of ischemia on the brain, why would someone with ischemia stroke develop cerebral edema?
Any clue, any answer to this question? Concepts that you can connect to chapter 2, when the metabolism ceased and the absence of blood supply, there is no ATP, adenosine triphosphate, and the sodium potassium pump fails. Do you remember that from chapter 2? When perfusion is inadequate, which is ischemia, then we don't have enough ATP production, adenosine triphosphate, which is the fuel for the sodium potassium pump. And what happens when the sodium potassium pump fails?
We retain water.
Right. So you have more sodium flow down the concentration gradient into the cells, and that will create what is called osmotic gradient, and develop the interstitial and intracellular edema. So more sodium, more water is going to be gushed and moved to the cells and create that cerebral edema. Number 4. Any volunteers for number 4?
What type of aphasia was Bonnie exhibiting when talking to her caregivers? Explain your answer.
So given the way that she was talking, patient was unable to articulate her words. Although it says that she, the patient, knew what information he was asking of her. So, given this description, we have two different forms. We have more than two, but two main types of aphasia. Before I go to these questions, just explain the difference between the expressive and the expressive aphasia, or what is called non-fluent aphasia. And there are two main types: expressive aphasia and receptive aphasia. With expressive, which is non-fluent, we call it non-fluent with expressive aphasia. The expressive or non-fluent aphasia, that's when the specific area in the brain is affected. Is called Broca's area, BROCA apostrophe S, Broca's area in the brain is affected, which is can you please unmute whoever is unmuted? So that's expressive or non-fluent aphasia. They have a difficult speaking, difficult writing. So they will have difficulty, to speak, to write. Now, receptive aphasia, which is usually referred to when the Wernicke's area in the brain is affected. WERNICKE. That's the area in the brain is affected. Wernicke's site in the brain is affected. And it's a sensory, but the expressive is motor. So receptive is sensory, Wernicke's area in the brain affected. So when the receptive, they have a difficulty understanding spoken words, difficulty understanding written words, and the speech often meaningless. They will talk on and on and on, but no meaning. You can't find any meaning to the sentences or phrases they are trying to tell you or to say. They are just, talking, saying words with no meaning, or sentences that is not connected, it doesn't have any meaning. Sometimes they make up their own words. Now we have also another type is called, so the two major ones, the two main types of aphasia, either it's expressive or receptive. Expressive, Broca's area is affected, motor site. Receptive, Wernicke's area in the brain affected, it's a sensory. And we have also mixed kind of combination of difficulty understanding words and speech, difficulty with reading and writing. That's a mixed type. And then the last one is the global aphasia. These are the four major types of aphasia. The two main ones are expressive and receptive, and then we have mixed, and then the global. The global one, which is a profound speech and language problems, global. And often no speech or sound that cannot be understood. So I will go over the global because we have a question on the global aphasia and explain more about the global one. So because this, aphasia is a very important concept in stroke, and we have to at least understand the basics of why patients would have this problem. So the answer is that Bonnie, or the patient, was expressive or what is called non-fluent aphasia, which is basically because of the Broca's area in the brain is affected. And this type of speech is characterized for our patients. Let's just go back to the slide. Sorry. Yeah, number 4 is that it's expressive or non-fluent aphasia. And this type of speech is characterized by verbalization that are meaningless and performed like the patient will talk like meaningless kind of words. The Comprehension, however, and expressive non-fluent aphasia. Comprehension, however, is unaffected. Patients, as they do understand. We're trying to tell them, we're trying to ask them or request from them. They understand. The comprehension is not unaffected. But the individual, so they know what is being said by others. However, they are unable to respond. They are unable to to express themselves in words by answering the questions or answering these the requests or answering what they are they are told by others. One more question about on stroke. Volunteers?
I can read.
Sure.
Anna Bryan, an 88-year-old Caucasian female, is brought to the emergency room by her daughter, Pat. Mrs. Bryan complains of right-sided weakness, a severe headache, and not feeling well for the last couple of days. Upon assessment, she is alert but has trouble answering questions. Her speech is slurred and she appears frightened. Which additional clinical manifestations would the nurse expect to find if Miss Bryan's symptoms have been caused by a stroke?
A bruit.
Carotid Browy. Right. So the patients are classified as asymptomatic without symptoms or symptomatic. So either they have symptoms or no symptoms. Now, the asymptomatic patients are usually referred to for what is called the carotid duplex ultrasound because they will be at risk for stroke or because the presence of a cervical bruit. So anytime the presence of the bruit, and I mentioned that earlier about the presence of the bruit, carotid bruit, it's significant because that indicates that there is a blockage in the carotid arteries, and that would put the patient at risk to develop the blood clot because that decreases perfusion, and it's a occlusion in the carotid arteries, and that could be a risk factor for patients to develop the stroke or CVA. Next, other volunteers.
While assessing Miss Bryan every 15 minutes, which of the following findings warrants immediate action?
B, bilateral grip strength is unequal.
And why do you think this is the correct answer, Alira?
That was me, Jeanne.
Oh, okay, Janet, yes.
Well, because that is a problem. Why is she having unequal strength, right?
Because one of the side, right? One side is weaker than the yeah. Exactly. Which is a sign of stroke, right?
Yeah.
Good. Yeah. Last question.
Due to her deteriorating condition, Miss Bryan is immediately referred to the neurologist. This patient has likely suffered a left-sided brain attack. Which clinical manifestation further supports this conclusion?
So left side brain attack. I know that you have expertise in the difference between right and left side, but the left side brain attack, eventually, patients tend to develop global aphasia. No, global aphasia. And I'll explain just briefly the difference between, because we have the slide, that slide here, this one give you some differences between right side or like right brain or left brain damage. So it's the global aphasia. It's not listed here, or Yeah, but that's would it be that would result from patients with left side brain attack or CVA, global aphasia. So the right cerebral hemisphere is more involved with visual. The right cerebral hemisphere is usually connected or involved with visual and spatial awareness. Like when we say spatial means you know where you have a sense of body position. You know where you are, sitting, you are standing. So that's what's called the spatial awareness and the proprioception, sense of body position. The person who has a stroke involving the right cerebral hemisphere, they will be unaware and they are unaware of the deficits that may be so that and maybe disoriented, unaware of any deficits, like they have problem with the spatial and proprioception, which is a sense of body position, and they have a problem with disorientation, which is disoriented to time and place. They will have also personality problems like impulsivity, poor impulse control. They cannot control, like, their actions. They cannot control their movement, and they have impulsivity and poor judgment. That's for the right side of the brain, right cerebral hemisphere. The left side, or cerebral hemisphere, left cerebral hemisphere, is the dominant hemisphere in all about in all, like all humanity or human, or people, but about 15 to 20%. I'm sorry, the left side or left cerebral hemisphere, the dominant hemisphere, in about from that percentage, I'm just giving you the percentage out of the 12, 20, if that's 15 or 20. So it's all human, all people except for like 15 or 20%. The left cerebral hemisphere will be, I would say, it's dominant for in about 80 to 70 to 80%, 80 to 85% of the population. They have the left side as the dominant hemisphere. So the left side is the center for language, mathematic skills, and analytic thinking. It's like critical thinking. So when the stroke affects the left side, given that, we said the most or all but 15 or to 20% of the population, they have the left side of the brain is the dominant one, and it's responsible for language, mathematic skills, and analytic thinking. Therefore, the stroke that affects the left side of the brain would result in aphasia, in what is called agraphia. Agraphia means difficult writing. Aphasia, inability to speak or comprehend language, and other problems connected to, like, the math, difficulty with mathematical calculations, and difficulty with reading. So the patient, usually when they have this dysphagia or problem with aphasia or agraphia, or they have problem with with the speaking issue or unable to express themselves in language, we will collaborate and send them or a request for SLP evaluation, which is speech language pathologist, to perform a complete assessment on them and find out the best strategy to treat that. Dysarthria, which is slurred speech, dysarthria, which will result from the loss of motor function of the to the tongue. This problem on this slide is called the hemianonymous hemianopsia. You can call it just hemianopsia. Hemianopsia, in which that half of the visual field will be lost, given that's right side CVA or right brain attack or left brain attack, or a CVA that affected the right side or left side of the brain. But that will eventually affect the half of the visual field will be affected, and that's what is called, we call that hemianopsia or hemianonymous hemianopsia. These two terminologies can be used interchangeably used. Meningitis, which is the infection of the meninges of the brain linings, and one of the slides shows the Brzezinski's and Koenig signs. Both signs are also will be presented in patients with meningitis. Encephalitis, which is an infection. So in the last 15 minutes, I know that we have two presentations. Is that okay with everyone if we stay like 15 or 20 minutes long? I mean, after the classes ended, or the after the time in class time is done, like 10, what is it, 9:45. Probably we need like about 20 minutes to do the presentations after that, maybe like 10 after 10. If that's okay with everyone for 10 after 10, that's fine. If you leave, because that will be recorded, so you are not going to miss anything if you leave. And if you have other commitments, other classes, or or work schedule or something that you have to leave at 9:45, we might stay like longer for the presentations. So the multiple sclerosis, which is a progressive inflammatory demyelinating disorder, which means that this slide explains the MS, in which that remember I always said that in Parkinson's disease that the slow motion and the bradykinesia, and that that's kind of concept of the anytime the neurons are affected, that would result in the slow movement, or the here it's, I would say, similar to that concept, in that the neurons will lose its protective sheath, and that sheath, which is the myelin sheath, which is responsible for the speed of the impulse, for the nerve impulse. So the nerve impulse will take a faster speed, or faster speed when the myelin sheath is present. When the myelin sheath is gone and destroyed, then that is going to result in very slow motion and very slow impulse movement. So the speed of that impulse will take longer. So the MS, it's progressive. It doesn't mean that patient will have all these signs and symptoms all of a sudden. It's going to be over years, over time, that the patient will have these kind of symptoms will getting worse and worse as they age, or as they progress into that disease process. So it's progressive inflammatory, and there is a loss of the myelin sheath which covers the neurons. Too many types of MS and too many classifications. Just going over the basics of the multiple sclerosis. Anyone ever had an experience with patient with MS?
Yeah, I have. I've worked with someone with MS before.
And can you just describe briefly any symptoms that pertains to MS?
So I know that it can gradually get worse. It can start with them not being able to move their hands, and it can get worse, like where they can't move anything at all.
Mm-hmm. Yeah. Very progressive. You will be stunned when you see cases. They are like in their 20s or 30s. They're in the wheelchair. They're unable to control their bowels or urinate, urine, or they are unable even to feed themselves. And it's very devastating to see. And it's very individualized too. Is that the can progress to, or to the last stage or advanced stages on their 20s and 30s. Others will take like longer, like their 40s and 50s. But it's a progressive disease, and it takes develops over time. So still the etiology is unknown, and it's believed to be infectious and immunologic. So immune system, in terms of the this slide explains about the antibodies that okay. So we would say that the cause is unknown, but it could be that it's related to the infections that affect the nervous system, or which is the brain and spinal cord, the fibers or the nerve fibers of the brain and spinal cord, in which they lose that myelin sheath due to the infections or immune reactions or immune responses. Some would say genetic factors. So the multiple sclerosis will be characterized by something called glioses. Gliosis, which is the scarring from that inflammation and the nerves or neurons, then that will result in glioses, Gliosis, and that's which is the scarring with the late degeneration of the axons in the central nervous system. It's believed to the disease process believed to be one of the theories that will explain the multiple sclerosis is that it's an autoimmune disease, which has been orchestrated or caused by an autoreactive T cells, like the T cells would attack the myelin sheath and destroy it as an autoimmune disease. And the destruction of the myelin sheath that will result in, as we said, the scarring, the glioses, and the changes would result in a plaque formation with plaques scattered throughout the central nervous system. And anytime you'll find the absence or destruction of the myelin sheath, that's going to result in a very slow motion, because the presence of the myelin sheath makes the nerve impulse go faster along the nervous pathway. But when it's absent, then it will take longer, and it takes a while. And you see that also in the patient's behaviors and patient's activities and ADLs and inability even to take care of themselves. So they go into like remission exacerbation. It's progressive disease, but also it's chronic in terms of the patients. At some point, they will have heightened signs and symptoms. Other times, they will have remission, less signs and symptoms. It's not heightened. I have a case study, but I'm just going to skip the case study and go to the Guillain-Barré syndrome. The Guillain-Barré syndrome, which is another disorder that affects the peripheral nervous system, and it's the belief that it is the inflammatory process that will also destroy the myelin sheath of the peripheral nervous system. Guillain-Barré syndrome, we call it GBS, as an autoimmune disorder that's characterized by, it says here that, varying degrees of motor weakness and paralysis. And you will be surprised to hear from the patients with the GBS that they are just woke up unable to move their lower extremities. And they just, woke up from sleep that they are unable to walk, or they have numbness, lower extremities. So it starts there are different forms of that GBS. The most common pattern of this disease is that it starts as the ascending form, which means it starts with the feet, up to the lower extremities, and then to the abdomen, and then to the chest. And that's when the patient will have a complete paralysis of the breathing or respiration, the respiratory muscles or muscle of respiration, and then that's when it would affect the lungs, and then the patient would have respiratory failure, and they will be admitted to the ICU and be on mechanical ventilation. And that's the GBS. As we said, there are different patterns and forms of that. The most common one, which is the ascending form, that patient experienced the numbness and the weakness, and it's an ascending form going from down up, from the bottom up, from the feet to the lower extremities to the up to the abdomen to the chest. And still there are a lot of I would say no misconceptions, but they are areas are not fully understood about the GBS. They try to treat it with, given that it's understood or believed to be an autoimmune disease and the presence of antibodies. So there is something called the they clean the blood from the antibodies, plasmapheresis. That's one of the techniques to treat patients with GBS, and they believe if that's an autoimmune disease, let's try the plasmapheresis. If you filter all these antibodies from the blood, then patients supposed to reveal, or patients should experience some improvement. So on lots of scenarios of patients with GBS, they being treated with plasmapheresis, and they showed significant improvement. So that's why they lean to believe that this is an autoimmune disease, and the antibodies attacking the myelin sheath resulted in that disease, and in the plasmapheresis is effective. So that's all I can say about GBS, given not much of even discussion or coverage in the book. Myasthenia gravis, MG. So we have MS, GBS, and then we have the MG. The MG is a neuromuscular junction disorder. So we need to understand the function of the acetylcholine at the neuromuscular junction. So it's a chronic autoimmune disease, the MG. The immunoglobulin type G antibody, it will attack the acetylcholine receptors. Now, for the muscle to contract, if this is the neuron, the end neuron, neuromuscular junction, neuron, and this is the end muscle, neuron. So the acetylcholine is supposed to, muscle, at the end plate of the muscle, they're supposed to be receptors, and acetylcholine released into the junction by the end neuron or ganglion, and that will supposed to activate the receptor at the muscle site, and then that's where in which that the contraction would begin or start. So the muscle contraction will be activated by the acetylcholine activation of the acetylcholine receptor. Now, if these receptors are going to be destroyed, then we will have acetylcholine with no effect on these receptors, which means that the muscle will stay in its relaxation phase and it's not going to contract, and that's going to affect the swallowing, because mastication, swallowing is controlled or governed by by the muscles of mastication, which is the muscles in the face and the and the mouth. So the swallowing will be affected. Talking also is a problem. Chewing food will be they will face or encounter difficulty chewing food. Diplopia or double vision, because of the muscles or the six muscles that control the gaze, or the ocular muscles, will be affected. So the receptors at the what is called the acetylcholine receptors, they are going to be destroyed by the antibodies, IgG antibodies, being attacked, attacking the acetylcholine receptors. So that will result in weakness and fatigue of muscles of mostly affect the eye and the throat. So that will result in double vision, diplopia, difficult chewing, and difficulty talking, difficulty swallowing. dysphagia, not dysphasia, dysphagia. It's a chronic disease also characterized by weakness and primarily in muscles that are innervated by the cranial nerves. Now, it's one of the also on theories that which explains the connection between the thymus gland and the MG, and that's some cases or scenarios. Patients with MG, they treat them with thymectomy. They remove the thymus gland. We know that thymus gland, as we get older, that's going to to get smaller and smaller. But they believe that when there is a tumor that affecting the thymus gland, that could be the cause or the pathophysiology or the risk. The factor which has resulted in the MG. So the causative factor, if that's the etiology, the thymoma, then in some cases, patients has been treated with thymectomy, surgical removal of the thymus gland, which is because there is a tumor. So, thymoma, which is a tumor, and the removal of that tumor, it revealed some positive effectiveness from the surgical removal of that tumor. In some cases, with the MG. So these are the most common symptoms as listed. Too many types, again, of the MG, like neonatal, affecting just neonates. We have congenital, patients are born with myasthenia gravis. If developed during the early childhood or juvenile myasthenia gravis. There are too many types. So just the MG, to know the basic pathophysiology about the acetylcholine, and the acetylcholine receptors are being attacked by the immunoglobulin type IgG antibody, and that would result in the manifestations that are associated with the weakness and fatigue of the muscles of the eye and the throat. And acetylcholine, this one, you will have this in pharmacology, in which that you will see that the acetylcholine, it has a life cycle, and the acetylcholine at the receptor will be splitted into, will be like metabolized into acetylcholine, into choline and acetate by the enzyme called acetylcholine esterase. It will kind of split into choline and acetate. Choline will go back and be part of the manufacturing or synthesis of a new choline, acetylcholine, and then the acetate will be a kind of like a waste product. But the acetylcholine esterase is one of the integral components or concepts in pharmacology as we treat patients with MG. Because if we antagonize the acetylcholine esterase, because this is responsible for the splitting and metabolizing the acetylcholine. If you inhibit the acetylcholine esterase, this is the receptor. If you inhibit the receptor, then you will have more of the acetylcholine available to activate the muscle and to prevent that weakness. And so that's just one of the principles for the treatment for patients with acetylcholine, or with the MG, with myasthenia gravis. The last, this is the, I intended to spend like 15 minutes talking about the receptors, and this is the what is called the sympathetic and nervous system, sympathetic nervous system, and we call this in neuropharmacology, as each receptor, when it's activated, would result in a physiological outcome. Just minimize it. Anyone recall this from like EMP or any other classes? Anything that pertains to the nicotinic receptors or see how it says like M and A and B, and then nicotinic receptors, muscarinic receptors, or alpha receptors, beta receptors, which is the adrenergic alpha or alpha 1, alpha 2, beta 1, beta 2. Any recall from other courses just to see what's the basis or yes. I didn't hear you, I'm sorry. Any clue from, or if you recall this from previous courses?
I know that parasympathetic is rest and digest, and sympathetic is fight and flight, right?
Right. Yeah, let's just go very brief because this is one of the, I would say, very important concepts because you can go to the pharmacology with this foundation, and I would say that this is a solid foundation to understand the neuropharmacology or neuropharmacologic agents. In pharmacologic agents is based on these two slides. If you understand these two slides, it's very easy to understand all the drugs that works on these sympathetic and parasympathetic nervous system. So we have receptors. If you look at these, so you have these receptors, it's at various organs. Let's use this one, maybe much, better. See how's let's start from here with the heart, and then sympathetic and parasympathetic. If you activate the parasympathetic, it's going to slow the heart rate. But the activation of the sympathetic, it will accelerate the heart rate. So if you activate the parasympathetic nervous system, because each organ is innervated by both sympathetic and parasympathetic. So if you target the parasympathetic, so let's say the patient is bradycardia, I'm gonna give them a drug to make the heart beat faster. So I want to treat the bradycardia, heart rate is 50. I want it to go up to 70. So I will give them drug that is going to activate this nerve or this nerve ending or the parasympathetic, the sympathetic nervous system or nerve. So you give them atropine, for example. Atropine is going to be a sympathetic nervous system stimulant. So which will accelerate the heart rate. So receptor binding. Receptors, you give a drug that is going to activate the receptor. If this is the receptor, we different types of receptors given the skin. Is it the skeletal muscle? Is it various organs? Is it sweat glands? It depends on the tissue or gland or organ. Each one has a different type of receptor. Muscarinic receptor, and it stands for the nicotinic, and the M muscarinic receptors, and then the alpha, which is the adrenergic receptors, alpha and beta, alpha 1, alpha 2, beta 1, beta 2. So binding to the receptor, either it will activate or block the receptor. So we call it agonist when the drug activates the receptor. If it's going to antagonize, it will block it, and it will be called an antagonist. Like when we say beta blockers, it's the same as when you say beta antagonist. So you are antagonizing the beta receptor, alpha or beta 1 or beta 2, such as metoprolol. The metoprolol is a drug to block the beta receptors in order to lower the blood pressure. And the mechanism, you will go over this in pharmacology, how blood pressure meds control blood pressure with different mechanisms. But again, this is just going to give you the very basic. I know this is not insufficient, but at least just to start, to read about it. I'm not requiring this, as part of the pathophysiology, but it's just I meant to give you an introduction to the neuropharmacology, so that when you go to the, advanced level, which is the junior level, to the forum in next fall, you at least you can refer to these slides. You can review the content from the textbook, so you understand the neuropharmacology or the effect of the drugs on the nervous system, agonist versus antagonist. So I'm trying to stop the recording. Any questions before we go to the presentations? So we'll keep, the recording on going, so that the presentation will be recorded as well. Okay, so no questions before we go to the presentations. Questions? Okay, so let's go to the first one. Who's presenting first? Seizures? Who's ready? Seizures or the Parkinson's?
Parkinson.
Okay, go ahead. You can share if you want to share your slides with us.
Felicity, are you ready?
Yes, I'm ready.
Okay, so okay, Cindy and Felicity, we're gonna present on Parkinson's disease. Okay, what is Parkinson's disease? Parkinson's disease is a neurological illness caused by degeneration or breaking down of cells in the central nervous system. It affects the motor system, which is part of the brain that conducts movement, and gets worse over time. So Parkinson's disease is the second most common neurodegenerative disorder after Alzheimer's. Physiologically, the symptoms associated with Parkinson's disease are the result of the loss of number of neurotransmitters, most likely dopamine, which is a part of the brain that produces the chemical. The dopamine is responsible for sending messages related to movement and coordination within the brain. So when the dopamine level drops, it's harder to control or coordinate movement. Parkinson's disease, the level of the dopamine drops over time and the symptoms get progressively worse. There is strong evidence that Parkinson's disease affects the dorsal motor nucleus of the vagus nerve and the olfactory bulbs, then the locus coeruleus, and eventually the substantia nigra. The cortical areas of the brain are affected at a later stage. The cause of Parkinson's disease still remain unknown, idiopathic, but scientists believe that a combination of genetic and environmental factors play a role. Researchers don't know why some people develop Parkinson's disease, but 10 to 15% of all Parkinson's disease cases, they are from genetic disorders, history of head injury, sometimes, and environmental exposure to toxins. So 2% of people with Parkinson's disease are 65 years old or older. I let Felicity talk about the signs and symptoms and the stages of the Parkinson's disease.
Okay, so the signs and symptoms of Parkinson's disease are hand tremors, gait and balance problems, bradykinesia, which is slow movement, limb rigidity, the limb becomes rigid, slurred speech, the speech sometimes it doesn't make sense, and reduced facial expressions. So stages of Parkinson's disease. Stage 1. At this stage, there are many symptoms. They are not severe enough to interfere with daily tasks and overall lifestyle, but family and friends may notice changes in your posture, walk, or facial expressions. In stage 2, stiffness, tremors, and trembling may be more noticeable. Stage 3, however, you are more likely to experience loss of balance and decreased reflexes. Your movements become slower. Falls are more common in stage 3. Stage 4. During stage 4, it's possible to stand out without assistance. However, patients may require a walker or other type of assistive device. Okay, so risk factors. Risk factors are age. It is usually common at age 60 years or older. Hereditary, family history of Parkinson's disease. Sex. Men are more likely to get Parkinson's disease than women. And then also exposure to toxins can also cause Parkinson's disease. Okay, so with diagnosis, positron emission tomography, PET, which is called PET scan, can be ordered to check dopamine activity in the brain. Lewy bodies, which are clumps of protein, can form in the brain to affect a person's memory function and body coordination. This aids in diagnosis in the later stages of Parkinson's disease. Okay, so for treatment, there is no cure for Parkinson's disease. Treatment options can help control the symptoms. Medications can help control symptoms such as movements, tremors. Most common medications such as car- carbidopa, 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 levodopa, carbidopa levodopa serve as a substitute to increase dopamine in the brain. Surgical procedure such as deep brain stimulation is normally offered to patients with advanced Parkinson's disease who are not responding well to medication. Also, lifestyle changes such as healthy eating and exercise can also reduce the symptoms of Parkinson's disease.
Okay, good. So next group. Next group ready?
Yeah, we're ready.
Money and okay.